we've already discussed about the innate immune systems in detail, but now we are moving on to the adaptive immunity. To get into hold of adaptive immunity, you have to know about the basics. We are actually moving into a transition area into adaptive immunity, where you have to know about the cells of the adaptive immunity and the organs that contribute to the adaptive immunity. So let us discuss the cells that contribute to adaptive immunity first. The moment you tell about adaptive immunity, only two cells that come into mind are the B cells and the T cells. So let us discuss on the cells. So first one are the T cells, let me put here, and the second one are the B cells, let me put here. So if you ask me how they come, where they originate from, the origination of both the T cells as well as the B cells is going to be the bone marrow. The bone marrow is the primary area where both the T cells and B cells are actually formed, but how they form is something different. How they form is going to be like some lymphocyte precursor or lymphoid precursor cell. I'm not giving a good clarity on that, I know that, but later on, once we see the development of the T cells and the B cells, you will understand the things in a good clarity. But right now, let us know that they are going to be coming as a lymphoid precursor cell. This lymphoid precursor cell is something uncommitted. They can become a B cell or they can become a T cell. Suppose if a cell commits into the T cell lineage, suppose if the T cell commits into the T cell lineage, they are going to leave the bone marrow. They are going to leave their home and they are going to leave the bone marrow, and they are going to enter an organ called thymus, where they are going to mature and get educated, and they become a complete T cell. So this is what is going to happen. A lymphoid cell which is not committed to the T cell lineage, obviously it's going to get committed to the B cell lineage, which means they stay in the bone marrow. They stay in the bone marrow, where within the bone marrow they are going to get mature. So the maturation process of the B cells happen in the bone marrow, maturation process of the T cells happen in the thymus, where the origin of the B cells and T cells both happen in the bone marrow only. So what is the thing that makes the lymphoid precursor commit into a B cell or a T cell? Very important, it's about the Notch signaling, which I discuss in detail. So no Notch signaling means they will commit to the B cell lineage. If it's a Notch signaling, they will commit into the T cell lineage, which leaves the bone marrow. Notch signaling makes the lymphocytes leave the bone marrow, and absence of Notch signaling will make the lymphoid cells stay within the bone marrow and become B cells. As simple as that. We'll discuss in more detail about Notch signaling in the next video regarding the T cells. And now once the Notch signaling has been done and the T cell has committed, you know that the thymus is the area where the T cells are going to mature, and the T cells, this T cell lineage lymphocytes, once they enter the thymus, in the thymus they are also called as thymocytes, which means you can call lymphocytes in the thymus lymphocytes. That's why they call them as thymocytes. So, because there are many students who confuse between the difference between a thymic epithelial cell and a thymocyte. Thymic epithelial cell is the cell of the thymus gland itself, whereas thymocytes are the lymphocytes that enter the thymus, is what we call thymocytes in basics. Okay, so let us move on ahead of this. Next thing, where they are distributed and what is the proportion of the cells in the blood. In the blood, the T cells contribute to 80%, whereas the B cells are going to contribute only to 20%. Remember, even though this is a big irony, even though only 20% in the blood is contributed by the B cells, actually the B cell lymphomas or the neoplasms are the ones that contribute to 85% of the lymphomas, and the T cell lymphomas contribute to only 15% of the lymphomas. This is a very big irony. Even though the number of T cells in the peripheral blood is more than that of the B cell, from the lymphoma perspective, the B cell neoplasms are the most important one. That's why the B cell maturation is what is given in tremendous detail in a lot of textbooks, because the B cell neoplasm, the lymph node structure, is what is very important in understanding stuff. And after this, if you ask me, what is in the T cells, which T cells contribute, whether CD4 lymphocytes or CD8 lymphocytes. Obviously CD4 is more in the ratio of 2:1, even though this ratio can be reversed in disease like HIV, where CD4 cells are killed and CD8 will go for reactive hyperplasia. So, but in general, in normal individual, the CD4 T cells are more in number compared to the CD8 T cells, which is very important to understand in the peripheral blood. And next thing, what we have to see is the tissue distribution, where they are typically distributed, the T cells and the B cells. The T cells and the B cells are typically distributed. The mature T cells is what I'm going to talk about. It's not about the primitive cells which are present in the thymus. The mature T cells and the B cells are present in the perifollicular, not in the follicular, perifollicular areas, which are nothing but seen in the cortex of the lymph node. I mean, this is one of the areas in the cortex, not the cortex. Perifollicular is one of the areas in the cortex of the lymph node. This is where you see the T cells. And typically you will see in the periarteriolar area of the spleen. Periarterial lymphatic sheath, that's so called PALS, pulse, that is where you see the T cells in the spleen. Whereas B cells are typically seen in the follicles, or otherwise simply you can call it as the germinal center. This is where you typically see the B cells. And not only in the follicles of the lymph nodes, these B cells can also be seen in the follicles of the spleen, follicles of the respiratory tract, and follicles of the GIT as well. So these are the areas where you typically see the B cells in general. But remember, very important point, follicles and perifollicles. So that's where you see, and periarterial region of the spleen. So this is where you see the T cells, and follicles is the place, or the germinal center is the place where you see the B cells in maximum numbers. And what are the surface markers? Surface markers of B cells and T cells. The moment you call about the surface markers of B cells and T cells, the first thing that comes into mind is the CD3 for the T cell. The CD3 is the most important. Many books do refer to this as a pan T cell marker, because this CD3, if present, that confirms the T cell lineage, and which means it's seen in almost all the T cell lineage cells. CD3 is a very important T cell marker, seen in almost all the T cell lineage cells. That's why it's called a pan T cell marker. And CD19 is often considered as a pan B cell marker. Obviously, this is going to be seen in almost all the B cell lineages as well. CD3 and CD19. If you ask me what are the other B cell and T cell markers, other T cell markers include CD2, CD4 and CD8. Remember why I am writing like this is because T cell may have a CD4 or a CD8, but never both. But they may not have both CD4 and CD8. That is also possible, but they cannot have both CD4 and CD8. That is impossible. So CD4 and CD8, very common scenarios, they have either CD4 or CD8. That is the commonest scenario. And CD6 and CD7, all these things are generally considered as a these are considered as a T cell lineage markers. And what are the other B cell lineage markers? You have CD20, very important one. And in exam, apart from CD19, they might ask CD20 also, because a lot of drugs are targeted against CD20, like rituximab, ocrelizumab, a lot of drugs are there. Like CD20 is one of the commonest targets for monoclonal antibodies, especially in autoimmune disease and cancers as well. So you have CD22, then you have CD9, then you have CD10, then you have CD79A and CD79B, and all these things. Apart from the HLA class 1, class 2 may be seen in both T cells as well as B cells. We are not going to discuss about that. But if you ask me what are the things that are important, probably the CD7A and B is important, and CD19, CD20. These are the two markers that are very, very important from the B cell perspective. In that, if they ask you CD9, where you see, you will see in the pre-B cells, and CD10, where you see in the precursor B cells. Precursor B cells. These are the areas where you see CD9 and CD10. But anyways, these are the two most important markers, as I already told you. And what are the receptors? What are the receptors for T cells? Classically, very simple. T cell receptor we called as TCR, and B cell receptor are going to called as BCR. What are the components? T cell receptor is going to have alpha and beta, called as alpha beta T cell, or it can have a gamma and delta component, which is called a delta gamma B cell, or a gamma delta B cell, or a delta gamma B cell. These are the two characteristic, types of T cell, which is the commonest. If they ask you, obviously 95% of the T cells are typically alpha beta chain having T cells. And what are the B cell receptor? B cell receptor is nothing but the immunoglobulin itself. It is the immunoglobulin that forms the B cell receptor. What immunoglobulin? Typically either IgM or an IgT. Very commonly Ig, IgG, Ig are also seen in some B cells, but typically IgM or IgT are the commonest forms of B cell receptors. It is nothing but the immunoglobulin that you normally see that is on the surface of the B cells, and that contributes to the B cell receptor. It's the immunoglobulin, that's all. Obviously, since it's an immunoglobulin, it's contribute of heavy chain and it's contribute of light chain. Light chain can be either kappa or light chain can be either lambda. Remember, heavy chain could be anything. So you have a lot of heavy chains. You have epsilon, gamma. That's the one that gives rise to your class, IgG, IgA and all these things. But kappa, lambda are light chains. Immunoglobulin may have either a kappa or either a lambda. So these are the heavy chains are the light chains. Anyway, we're going to deal with the structure of the immunoglobulin in the subsequent videos. But anyway, right now let us only know this thing. So what are the function? If you ask me about the function, it's a very primitive question to ask about the function. B cells are, as per microbiology textbooks, they are humoral immunity, but they are more than that. So which are going to generate antibodies, by differentiating into plasma cells. Whereas T cells is more of a cell-mediated immunity, CMI. Where CD4 we typically call as helper T cells, because it was thought that this CD4 class of T cells helps the B cells in generating antibodies. So that's why they're called helping B cells in generating antibodies. That's why they're called helper T cells. But we know that CD4 cells are more than what we thought previously. And CD8 T cells are nothing but having cytotoxic function. Again, their function is more than what we thought previously. But this is a very primitive and preliminary discussion about the CD4 and CD8 T cells. So these are the basic differences between the T cells and the B cell. And once we know these things, we have to discuss on the lymphoid organs, which itself is a beast. So much is there on the lymphoid organs to understand, because understanding these lymphoid organs of paramount importance, especially the lymph node structure, to know how the B cells mature and to understand where you get the B cell neoplasms. Because different area of maturation in the lymph node of the B cells will give us to different neoplasms, which have a beautiful diagram later on to be discussed. So right now, let us assume what are the two types of lymphoid organs. One is the primary lymphoid organ, second one are the secondary lymphoid organ. So what are the primary lymphoid organs? The primary lymphoid organs are nothing but the areas where your lymphocytes are formed and matured. Where the lymphocytes forms and matures, maybe B cell or T cell, where the lymphocytes form and mature, that is where you call the primary lymphoid organs. By definition, only two areas they form and mature, that's the bone marrow and the thymus. So these are the two classic primary lymphoid organs. If you ask about the secondary lymphoid organs are the place where your lymphocytes are activated. Lymphocytes are actually activated, which means this is the places where your lymphocytes are ready for war, which means they are going to generate an adaptive response only at these sites. These are secondary lymphoid organs. So activation happens in secondary lymphoid areas and formation and maturation happens in the primary lymphoid areas. By principle, the secondary lymphoid organs are multiple. So you can classify into three groups secondary lymphoid organs. The first group is the simple tissue group. Second one is the intermediate group, and the third one is the organ proper or organus proper, that's the Latin name. So proper organs that form the secondary lymphoid organs. Simple tissues that give rise to secondary lymphoid organs are: number one, you have diffuse tissues, that is also called as MALT, that's called mucose-associated lymphoid tissue. Second one, you have solitary tissues, solitary lymphoid tissues that usually seen in the intestinal mucosa. And third one are the lymphoid aggregates that you generally see in the form of Peyer's patches in the intestine, especially in the ileum. Intermediate, typically only one thing is there, that are the tonsils, which are intermediate between this simple group and the proper organ. They do not comprise of the proper organs also, they are not simple tissues also. So that's why intermediate, these are the tonsils. You have four groups of tonsils, you know, the pharyngeal, palatine, then you have tubal, and then you have lingual tonsils. This form the Valdes ring, which got the, this forms the adaptive immune response at the entry of nasopharyngeal and nasogastric route, oropharyngeal and nasopharyngeal route, isn't it? So these got the entry of the organisms into us. So that's why these are called Valdes ring, first line of adaptive immunity. So proper organs wise, if you ask me, there are only two things. One is the lymph node and second one is the spleen. So these are the only two areas which contribute to the proper secondary lymphoid organs. So lymph node and the spleen. And to understand more about this primary and secondary lymphoid organs, let us see this diagram per se. So what you see in this diagram is about the primary lymphoid organs, which are major is the bone marrow and the thymus. The second lymphoid organ, the predominant ones are the lymph node and the spleen. You can clearly see the T cells always outnumber even in the bone marrow. Remember, even in the bone marrow, the T cells are going to outnumber the B cells, because the peripheral blood T cells are more in number compared to the B cells. Even in the bone marrow, the T cells are more in number compared to the B cells. I mean the T cell lineage cells. That's what I'm trying to tell. Even in the bone marrow. So primary lymphoid organs. So if you see what is going to happen, what I'm trying to tell is, see, leave the bone marrow, but in the thymus there are two zones. This is what we call the cortex, and second one, the deeper structure, is what we called as the medulla. In the cortex, you can clearly see from this image, they are actually TDT positive. The moment you call cortex TDT positive means, TDT always means the cortex will contain more primitive cells, which means they are immature cells. The moment you call it TDT negative means they are more mature cells. By analogy, the medulla is going to contain more mature T cells compared to the cortex. So this is very, very important. So that's why it's given more dark blue, green, more primitive cells, and light blue and green. I mean, this diagram gives rise to more mature cells. Similarly, in the secondary lymphoid organ, you are going to see mostly mature cells only. But I mean, anyways. But what you can see is like in the what you are seeing is the T cell areas and the B cell areas. You can see these are the follicles. These are the follicles. In the follicles, you can see typically the B cell zone, and similarly in the follicles of the spleen also you are seeing the B cells. This is very important, which we discussed already. In the follicles, you are going to see the B cells only. In the parafollicular area, for example, if you see in the parafollicular area, these are the parafollicular areas. These are the parafollicular areas. In the parafollicular areas and the periarterial area, this is the periarterial area around the follicle. So where you see the T cells in general. But what in striking contrast when compared to the primary lymphoid organs is that you can see like the more primitive cells here are actually seen in the center. You can see the center contains more primitive cells, and the surrounding is containing more mature cells, which is the exact reverse of what you saw in the primary lymphoid organs. For example, in the thymus. In the center, you had more mature cells, and in the periphery, you had more primitive cells. But whereas in the secondary lymphoid organs, the center contains more primitive cells, whereas the periphery will contain more mature cells. So that is how it's going to work. So these are some of the differences between the primary and the second lymphoid organs. Remember, like the T cell areas, the B cells are the ones that are going to be constant in the follicles, and the T cells will be either in the surrounding the follicles, or which is called as parafollicular area or perifollicular area in case of the lymph node, and periarterial area in case of a spleen. That is where you see the T cells. So very easy to understand, isn't it? So these are the things that you have to understand about the B cells and the T cells. Now we can talk about the primary lymphoid organs. Important primary lymphoid organs. So the most important primary lymphoid organ is the bone marrow. We have discussed enough about the bone marrow in the very first video on hematology. Lot of about things about what is the cellularity, the different components of the bone marrow, starting, what are the areas that contribute, how to examine the bone marrow, what are the indications, contraindications, everything we have discussed already in the first video of hematology. So I'm not going to discuss anything more. The second thing is about the thymus. Thymus is a very important primary lymphoid organ. So which is the place where you generate the T cells. These are the T cell factories. This is where you generate the T cells. Typically, the thymus is located in the superior and anterior mediastinum. Or simply you can call it as retrosternal and pericardial. Remember, that is the reason why, since the location is in the anterior mediastinum, that is the reason one of the important differential diagnosis for an anterior mediastinal mass is a thymoma. Very important differential diagnosis. So thymomas are going to result in anterior mediastinal mass because of the location, anatomical location. Then thymus is one of the very active glands in childhood. For example, if you ask me what happens in child, thymus usually is very large, whereas in adults they go for involution and they go for something called age dependent atrophy. They go for something called thymic involution and they go for something called age dependent atrophy. So that's what is going to happen, which means in the children this large thymus can be seen very prominently in the chest X-ray. In the chest X-ray is going to give rise to something called a thymic sail sign. So it's a very common question in the exam. What do you mean by thymic sail? Thymic sail is something you see in the chest X-ray, a prominent thymus shadow, very common in neonates especially and newborns. That is what the prominent thymic shadow in the X-ray is what we refer to as something called a thymic sail, which I will show you in some time. So these are things. So what are the components? So when you do a histology or a biopsy, what are the things you are going to see in the thymus? So remember, so two things, as I already told you, you have a thymic cortex and a thymic medulla. So thymic cortex is going to contain more of immature lymphocytes, immature T cells, which I have discussed already, whereas the thymic medulla is going to contain more of a mature T cells. Apart from this cortex and the medulla, immature and mature T cells, thymus also contains a whole lot of thymic epithelial cells. Remember, thymic epithelial cells are referred to as TECs. These are not thymocytes. Thymocytes are the thymic lymphocytes. These are thymic epithelial cells, which also is very important. They can have a lot of thymic macrophages and they can have DCs also. These are important for education of the T cells as well. So these are what we call, these are the different components that you see in the histology. And as far as the embryology is concerned, where the thymus originates from, thymus is said to originate from the third and the fourth pharyngeal arches. Third and fourth pharyngeal arches. So that is where the mnemonic comes from. So mnemonic means thymus for third. So this is what many books will give you a mnemonic. T for T, T for tat, thymus for third. So thymus originates from the third pharyngeal arch. And remember, thymus originates from the endoderm because pharyngeal arches itself are nothing but endodermal pouches only. So they actually originate from the endoderm. But irony is, these T cells that come for education, to the thymus, originate from the mesoderm. That's very important. The thymocytes, if they ask you where thymocytes, this is a very common, mistake done in exam. If they ask thymocytes, where they originate from, you have to tell they originate from the mesoderm. If they ask you thymic epithelial cells, where they originate from, you have to tell they are from endoderm, from the pharyngeal pouches, typically from the third pharyngeal pouch or the third pharyngeal arch. Very important and very confusing and, repeatedly tongue twisting question in exam. Then sixth one, we'll see about the clinical significance, applied aspects of the thymus. Number one, rarely see thymic hypoplasia. Thymic hypoplasia or aplasia is very common feature of a DGeorge syndrome. DGeorge syndrome, and second you can remember as SAID, severe combined immunodeficiency. But very common in exam, they will expect this DGeorge syndrome only, which you'll see in immunodeficiency video. Then you have thymic hyperplasia. Where you see thymic hyperplasia, very commonly you see secondary to chemotherapy. Many chemotherapies can cause thymic hyperplasia and use of steroid drugs, steroid therapy. All these things can result in thymic hyperplasia, very common reasons. You will see true hyperplasia. This is pseudo hyperplasia, true thymic hyperplasia or true lymphoid hyperplasia of the thymus. True lymphoid hyperplasia of the thymus is usually seen in very commonly in autoimmune disorders. A lot of autoimmune disorders can cause true lymphoid hyperplasia. Then you have two more things. One is called a thymoma. It's a very important question for entrance. Where you see thymoma? Thymoma is very uncommon in general, but usually typically presents as a anteromediastinal mass. I'll show you how you diagnose an anteromediastinal mass. Typically they're going to present with an anteromediastinal mass. Usual symptoms of this thymomas will be, typically the thymomas will happen in around 40 to 60 years of age, and usually they can be asymptomatic or symptomatic. Symptoms can be local symptoms like you can have a chest pain, you can have a cough, you can have shortness of breath or dyspnea, they can even present with SVC syndrome. This is how they present. Very commonly, they also have associated paraneoplastic syndromes, which means thymoma can be associated with a lot of paraneoplastic syndrome. Very commonly in exam, what they expect is myasthenia gravis. Myasthenia gravis is one of the very important paraneoplastic syndrome of thymoma, because remember, 15% of the myasthenia gravis patients may harbor underlying thymoma. Very important point. And number 2, they can be associated with pure red cell aplasia. Very important. Pure red cell aplasia. And third thing, there is a syndrome called immunodeficiency with thymoma, which means thymoma can underlie an immunodeficiency also. These two are the paraneoplastic syndromes, and the third one is the other associated thing with thymoma, that is immunodeficiency with thymoma syndrome. So these are the clinical presentation of how a thymoma will present. So the moment you call about this anterior mediastinal mass, it's also worth knowing what are the DDs, associated DDs for anterior mediastinal mass. Usually they think about the 4 Ts. 4 Ts are what we call as anterior mediastinal mass differential diagnosis. First one, we already know it's a thymoma or a thymic carcinoma or anything related to thymus. Thymoma or a thymic carcinoma, thymic CA. Second one is the thyroid. Thyroid means usually we are going to deal about retrosternal goiter. Retrosternal goiter. Third one is a teratoma, mediastinal teratoma. And fourth one, we typically call as something called terrible diagnosis. What are the terrible diagnoses? Typically a lymphoma or a aortic aneurysm, ascending aortic aneurysm. Typically an ascending aortic aneurysm can present as an anterior mediastinal mass. So these are the typical differential diagnosis. Very common mnemonic they ask in exam. These are the 4 T's of anterior mediastinal mass: thymoma, thymic carcinoma, comes under thymus group, thyroid, retrosternal goiter, which means then you have mediastinal teratomas, and then you have terrible diagnosis like lymphoma and ascending aortic aneurysm. So these are the differential diagnosis for anterior mediastinal masses. So finally, if they ask you what is the treatment for thymoma, definitely you have to go for surgery plus or minus chemo, radiation. So this is the treatment. But surgery is very commonly preferred for, the patient is having a paraneoplastic syndrome. And other than that, like majority of thymomas are usually resectable. Finally, you have something called thymic carcinoma. Thymic carcinoma is an extremely rare entity. You don't usually encounter thymic carcinoma, and usually very, very aggressive than a thymoma. And very commonly they will have mediastinal invasion and distant metastasis also. That is what is going to differentiate thymoma from a thymic carcinoma. But very rare entity. Thymic carcinoma you generally don't see. But putting all this thing in a nutshell, let us see some images. So this is a newborn image which is showing a prominent shadow of the thymus in the right hemithorax. So this is what is referred to as something called thymic sail. This is a normal sign. Understand, this is a normal sign in the neonates. This is called thymic sail sign. And this is abnormal actually. You can see in the PA views and you can see in the lateral views of the chest X-ray, where you can see an anterior mediastinal mass here typically, and you can also see a anterior mediastinal mass here. So how can you tell it's an anterior mediastinal mass in the PA view? You can see the vascular markings are very clear. Clear vascular markings. That is very important, because being an anterior mediastinal mass, it grows over the hilum and not pushing the hilum. So since it grows over the hilum, behind the mass you can see the vascular marking, especially the pulmonary artery, very clearly. If it's going to be a middle mediastinal or posterior mediastinal mass, very likely they will push the hilar structures and they will change the conformation of the mediastinal structures and hilar structures, and they will create indentations and all, and you can clearly see in the PA view of the chest X-ray. But here in this case, this mass is clearly over the hilar structures. They don't disturb the hilar structures at all. You can see the vascular markings very clearly without any kinking or with any compression. So definitely this should be an anterior mediastinal mass, and one of the important DD for anterior mediastinal mass is a thymoma. But in a lateral X-ray you can clearly see the anterior mediastinal mass because it's located in the anterior. This is a posterior, so it's located in the anterior area. And in the CT also you can see this is the area where you can see the thymoma in the CT. So that's an anterior mediastinal mass again. CT is one of the best investigations for diagnosing this. Anyways, so this is how you diagnose a thymoma or an anterior mediastinal mass. Then let us move on to the secondary, because we have discussed the primary lymph node organ. Let us move on to the secondary lymph node organ. So what are the secondary lymph node organs that are important? The first secondary lymph node organ that is important is the lymph node. Lymph node is a very important second lymph node organ. To understand the lymph node, it is always better to see with a diagrammatic representation. So that is why I'm going to show this diagram. So this is a very important diagram to understand the lymph node, cartoonic diagram. So first thing, you can see the structure of the lymph node. It's going to have a capsule. Any clinical relevance? Absolutely no. It's not going to have any clinical relevance, to be honest. But this capsule, when it is malformed, or when there is a capsular invasion by a mass, you can go for an aggressive type of lymphoma, but apart from that, it's not going to have any clinical relevance at all. So capsule is there. It's a fibrous capsule will be there in the lymph node. Then you have lymphatics. These are actually the afferent lymphatics you see here, and these are the efferent lymphatics that go out of the lymph node. So the afferent lymphatics enter here, and the efferent lymphatics go out over here. This is the afferent lymphatic and this is the efferent lymphatic. And you can see there is this capsule itself forms something called a trabecular sinus. These are called as trabeculae or trabecular sinus. This is the one you can see that takes the lymph and flows it through the efferent, into the medullary sinus and takes out through the efferent lymph. So the trabecular sinus is the one that takes the lymph from the cortex, runs through the medulla and pushes into the medulla so that they can go out of the efferent. The lymph flow is maintained by the trabecular sinus only. That again is a very important point. Then what else you can see is in the hilum. The hilum is the area where your efferent lymphatic comes out. At the same time, your vessels also go in and out. The artery also enters through the hilum only. The veins also come out of the lymph node through the hilum only. So that's what is going to happen. So when you take the microscopic structure of the lymph node, you can see cortical areas here. You can see the cortex. Cortex is this area, so which you can see. For example, this is the area of the cortex. In the cortex, you can see follicles, and you can see also the parafollicular areas. So which I am putting as a dot. These are the parafollicular areas. You can see our paracortical areas. You can see this is the paracortex, which I am putting in dots, and the cortex area, which I am putting in straight lines. So this is the cortex, this is the paracortical areas. So remember, the cortex is going to contain the B cells, and the paracortex is going to contain the T cells. Very important. This is the perifollicular area. Cortex also contains the, we can call it as your B cell area. B cell area are the ones of the follicles. So clearly, this is the follicle that contains the B cells, and this perifollicular area or pericortical area is where you get the T cell zone. And in the follicle itself, for example, if you take this follicle and zoom, so let me take the follicle and zoom. So this follicle is going to develop something called, he's going to contain two types of follicles called primary follicle and a secondary follicle. The primary follicle is going to contain, is said to be inactive because they will contain only naive B cells. And the secondary follicle is the one that develops within the follicle. For example, if these are going to contain the active B cells, these are going to contain active, or simply we can call it as, activated B cells. So if you take a follicle, an active secondary follicle, they will contain two zones, the central zone and the surrounding zone. The central zone is the one that is what we call as a germinal center follicles. The germinal centers are the ones that contain the active areas. So the surrounding one are the ones we are going to call as mantle zone. These mantle zones will contain, again the naive B cells, and the germinal center is the one that is going to contain active and proliferating B cells. So which means the germinal center is going to be pale as per the diagram, and the mantle zone is going to be dark. So how to understand this is, you have a follicle. The moment the B cells encounter an antigenic contact, the follicle, the lymphocytes will start, certain lymphocytes, not all lymphocytes, the certain lymphocytes will start proliferating. The proliferating lymphocytes will start accumulating in the center, forming the germinal center, and the lymphocytes that are not going to participate in the antigen fighting reaction is going to be accumulating in the sides, and that forms the mantle zone, which means mantle zone contains the naive B cells, and the germinal center in the center, which is pale, that is going to contain the like activated and lymphocytes that had the antigenic contact actually. So which means primary follicle means it's completely inactive. Secondary follicles is the active zone, but in the secondary follicle, the central germinal center, which is pale, is the one that is containing activated lymphocytes, and the surrounding mantle zone will contain inactive lymphocytes only. This is very, very important to understand. Remember, mantle zone will contain naive and inactive lymphocytes only. Only the central germinal center will contain the activated lymphocytes, which will be pale in histology. So that is what is extremely important to understand. And then coming to the medulla. So when you come to the medullary zone, you can see this is the medullary zone. And the medullary zone will contain many areas. For example, this medullary zone will contain medullary cords. Medullary cords, which I mentioned here. These medullary cords are nothing but these areas, which I am shading. So these areas are what we refer to as something called, these black colored areas are what we called as medullary cords, these shaded areas. These are medullary cords. These medullary cords are the ones that contain the plasma cells. If you ask me, typically they contain only the short-lived plasmablasts, because generally the long-lived real plasma cells are going to be seen in the bone marrow only, because they migrate to the bone marrow. But the short-lived, for short-term, short-span IgM secreting plasma cells may be seen in the medullary cords of the lymph nodes. And they are also going to contain the macrophages. They are going to contain the macrophages. And typically these areas, which I am going to put in dots, or we can use a different color, maybe I can use some yellow. So these areas are what we called as medullary sinus. These areas are called as medullary sinus. Medullary sinus. These medullary sinus will again contain macrophages and reticular cells. Macrophages and reticular cells. The medullary sinus is the one that is connected to the efferent lymphatics. You can see this medullary sinus is the one that is connected to the efferent lymphatics. So that is very important. And remember, the medullary cords also contain certain B and T lymphocytes as well. That's why I told you previously itself. So remember, the in a nutshell, you can divide into cortex and the medulla. So I can put it in a nutshell. So if you take a structure of a lymph node, you can put it as a capsule, so which is not of that much importance. Then you can tell about the cortex, then you can tell about the medulla, then you can tell about the hilum. Medulla, clear? Medulla and the hilum. So the capsule is a fibrous tissue, and usually it is not that important in real time. The cortex you can divide into follicular areas, and you can divide into parafollicular or perifollicular areas. Para or perifollicular areas. These follicular areas are the areas of B cells, and the parafollicular areas are the areas of T cells. Remember, in the follicles itself, there are two types. One is primary follicles, which had no antigen contact. These are lymphocytes which do not have antigen contact, and they are inactive. And you have something called secondary follicles, which are activated, where you see the activated B cells in the secondary follicles only. In the secondary follicles, there are two areas are there. One is the germinal center, and second one is the mantle zone. In the germinal center is the place where you typically see the activated B cells, which are undergoing rapid proliferation, and they're going somatic hypermutation and class switching and all. This will be usually in the center of the germinal center, and they will be usually pale in nature. And the mantle zone will contain the inactive, which is not participating in the fight. Inactive and naive B cells, inactive and naive B cells, and they will be in the periphery, that is surrounding the germinal center, in the follicle itself, surrounding the germinal center, and they will be usually dark in nature. So these are the ideas. So the parafollicular zone will contain the T cells. In the medulla, if you ask me, medulla is the zone where you are going to have two areas. One is called this medullary cords, and second one is called medullary sinus. The medullary cords typically contain two things. One is the short-lived plasma cells, as I told you, which are going to secrete antibody for only a short time, because long-lived plasma cells are in the bone marrow. Then they are going to contain certain lymphocytes, but most important component is the plasma cells. Similarly, in the medullary sinus, you are going to see the macrophages and the reticular cells. These are the components of the medullary sinus. And medullary sinus is the one that is going to form connection with the afferent lymphatics also. Forms connection with the efferent lymphatics. And hilum is actually a very important area to be understood. Boy, I tell you one important applied aspect in ultrasound is there. If you ask me about the hilum is the place where you have entry of the artery and the vein. I mean, artery enters and vein leaves the lymph node through the hilum only. And this is also the place where you get the efferent lymphatics. What is the important applied aspect of this hilum is, suppose when a radiologist want to do an ultrasound of the lymph node, so they will see whether the hilum is preserved or not. Hilum is preserved or hilum is distorted. If the patient is having an enlarged lymph node, lymphadenopathy is there and you do an ultrasound, if hilum, the nature of the hilum and the structure of the hilum is preserved, means in the presence of lymphadenopathy, it goes towards a reactive hyperplasia. Very commonly it's due to infection. Any viral or bacterial infection is a reactive hyperplasia only. But if hilum is distorted, it more goes towards a lymphoma or a metastasis. It more goes towards a lymphoma or a cancer metastasis. So if the hilum is distorted, the natural structure of the lymph node architecture is distorted, means it goes towards some malignancy. That is why one of the important aspects of the applied aspects of the hilum is all about. So this is how you classify the lymph node basically into capsule, like cortex, medulla and the hilum. I told you what are the cortical structures and what are the medullary structures in general. So these are the important differential things. So once you know about the lymph node, let us finish off some of the important aspects of the lymphadenopathy also. Let us finish off some of the important aspects of the lymphadenopathy also. So first, the most important thing they will ask you is very few things. Let us see first the etiology of the lymphadenopathy. The moment you you want to know about the etiology of lymphadenopathy, I used to give by a criteria called Miami criteria. So Miami is the mnemonic I used to give, and some standard textbooks also give this mnemonic. So M stands for malignancy, and I stands for infection, A stands for autoimmune, and M stands for miscellaneous. Here the next M stands for miscellaneous, and I is going to stand for iatrogenic. So let us see some of the important causes. When you call about the malignancy is a very important reason for a lymphadenopathy. Many malignancies can cause lymphadenopathy. For example, you have a lymphoma. Lot of lymphomas are there. Lot of leukemias, but leukemias causing lymphadenopathy is generally rare but possible. So leukemias can cause. You have something called amyloidosis can cause. Sorry, it's not a neoplasm. So leukemias. Then you have something called metastatic carcinomas, metastatic cancers. So these are the three things that are going to produce lymphadenopathy. Malignancy causing lymphadenopathy. Then what about the infection? A whole lot of infections are there. So I can split into number one into a viral infection. Very typically you can see in Epstein-Barr virus infection mononucleus, HIV, persistent generalized lymphadenopathy. Then you can see in HSV, CMV, then varicella zoster virus, measles, rubella, hepatitis viruses. Lot of viruses can cause lymphadenopathy, but I am oriented towards EBV and HIV only, because that is what exam points are. EBV, HIV. Mostly viral infections with lymphadenopathy means we go for EBV and HIV only, even though many other things can cause. Then second one, you have bacterial infections. Bacterial infections means then you can split into generalized lymphadenopathy and you have localized lymphadenopathy. When you have a generalized lymphadenopathy with bacterial infections, it more goes towards brucellosis, tuberculosis, syphilis, atypical mycobacteria, probably very rarely leptospirosis. These are the areas where you go for generalized lymphadenopathy, especially TB, syphilis, brucellosis. These are the usual reasons where you see generalized lymphadenopathy with the bacterial infection. Localized lymphadenopathy very commonly you see in pharyngitis, streptococcal sore throat. So streptococcus, staphylococcus, Then you can also see in cat scratch disease, very important for exams. Cat scratch disease and Francisella tularensis causing tularemia. So these are some of the important conditions where a bacterial infection is causing lymphadenopathy. Number 3, you have something called parasitic infections. Parasitic infections causing lymphadenopathy. What do you mean by parasitic infection causing lymphadenopathy? Toxoplasma, very important. Toxoplasma is the most important in this group. Then finally you have fungal infections causing lymphadenopathy. Fungal infections causing lymphadenopathy are histoplasmosis, coccidioidomycosis and paracoccidioidomycosis. So these are the fungal infections that generally causes lymphadenopathy. So even blastomycosis sometimes, but these are the fungal infections that causes lymphadenopathy. So these are the very important things. And here I have utilized a term called generalized and localized. What do you mean by generalized and localized? Actually the definition of generalized and localized is if there are at least 2 groups are involved, 2 lymph node groups are involved, plus they are non-contiguous. Non-contiguous. So non-contiguous in the sense like they should not be anatomically contiguous, next to each other. For example, cervical and inguinal, definitely it is non-contiguous only. Axillary and cervical are actually contiguous, so that will not come under generalized. But cervical plus inguinal, definitely it's going to be non-contiguous. Axillary may be involved, that is not an issue, but 2 non-contiguous groups, if it's involved, then we are going to call it as generalized lymphadenopathy. Localized means it's simple. I mean, any lymph node groups, usually 1 lymph node group only will be involved. 1 group usually will be involved, or you can call 2 groups may be involved, but it will be anatomically contiguous. This will come under localized lymphadenopathy. And there is another term called persistent lymphadenopathy. Persistent means if it exceeds 3 months. If the lymphadenopathy exceeds 3 months, we're going to call it as persistent lymphadenopathy. If you ask persistent generalized means 2 or more non-contiguous, anatomically non-contiguous lymph node groups are involved for more than 3 months, we are going to call it as persistent generalized lymphadenopathy or PGL. These are some of the definitions that you can know. And what about the autoimmune diseases? There are a lot of autoimmune diseases that can cause lymphadenopathy. For example, you can see in a lot of connective tissue disorders like SLE, rheumatoid arthritis, a lot of connective tissue disorders. In fact, the most common extra articular manifestation of rheumatoid arthritis is lymphadenopathy only. So lymphadenopathy is very common in connective tissue. Even Sjogren syndrome can produce lymphadenopathy. So connective tissue disorder. Then you can see in drug hypersensitivities, you can see in Castleman diseases. Castleman diseases. This one I think we can put under miscellaneous. So miscellaneous, you can put your Castleman disease, Kawasaki disease, then Rosai-Dorfman disease. A lot of things are there. Rosai-Dorfman disease. Then Kikuchi-Fujimoto disease, Kikuchi disease. All these things you can put under miscellaneous cause where you can develop lymphadenopathy. Finally, you have this iatrogenic causes producing lymphadenopathy. In this, the most important is the drugs that induce lymphadenopathy, iatrogenic causes. What are the drugs that can cause lymphadenopathy? First one is allopurinol. Then you have phenytoin. Then you can develop with atenolol. Then you can see with certain drugs like captopril, gold, penicillins, quinidin, primidone, cotrimoxazole, trimethoprim sulfamethoxazole combination, and carbamazepine. So these are the drugs that are generally associated with lymphadenopathy, to be honest, but in exam the most important will be the phenytoin. Phenytoin will be the single most important in exam because it's a multiple time asked question. Many times they have asked in the past and there is a lot of potential to ask in the future also because it is often associated with something called a pseudolymphoma. Very important. Very, very important point. So many other drugs also associated with pseudolymphoma, but this is a very important question for exam. That's why phenytoin and lymphadenopathy are very, very important. So these are some of the important causes. But in general, MIAMI is the mnemonic, easy to remember. MIAMI means malignancy. Then you have infections, autoimmune. Then you have miscellaneous group and iatrogenic. In the most common, if they ask you, infection group. Infection is the commonest reason for getting a lymphadenopathy. Most common reason. That is the usual reason. So malignancy, usually lymphoma, leukemias. That's one of the things that's going to be, and metastasis. And infection, a whole lot of infections. I told you, right from TB to HIV, a lot of infections can cause, and fungal infections and autoimmune connective tissue disorders. Miscellaneous, know about Kawasaki disease and Castleman disease. Maybe if you want Kikuchi disease and other things you can know, Rosa-Dorfman disease and all. Then finally you have something called iatrogenic. In the drugs, the most important is going to be the phenytoin. So these are the conditions that are going to produce lymphadenopathy. Knowing only the etiology of lymphadenopathy is not really going to help you. What it is going to help you is what are the signs of dangerous lymphadenopathy. That's also very important. So which means what are the reasons where you have to do a biopsy. Indications of lymph node biopsy. Number 1, age more than 40. Number 2, size more than 2 centimeter. And certain locations. Definitely you have to do biopsy. Especially best example is supraclavicular nodes. Supraclavicular nodes are very, very ominous. Like we call Troisier sign, especially if the left supraclavicular node is enlarged, it usually indicates a GI malignancy, especially ovarian or any other gastrointestinal or pelvic malignancy. Very, very ominous sign, Troisier sign, supraclavicular nodes. So location is also very important. Then duration. Typically, if it is more than 1 month, definitely it becomes an indication. And usually, if there is presence of B symptoms, is also an indication for doing. Like B symptoms are the classic. You can imagine like a TB symptom where you have fever, night sweats, weight loss. These are the things that are going to contribute to the B symptom. Presence of B symptoms, definitely have to do the biopsy. And associated hepatosplenomegaly, HSM, associated hepatosplenomegaly. All these things are absolute indications for doing biopsy. And one more thing, if they ask you, to diagnose a lymphoma, FNAC, that is aspiration, lymph node aspiration, that is what we call FNAC, or biopsy. Which will you prefer? The answer must be biopsy, always. Or which biopsy? Typically, it's better to do a excision biopsy. Very, very important. So whenever you want to diagnose a lymphoma, which means whenever there are features that are suggestive of a lymphoma, that are predictive of a lymphoma, all these features which I have told you, which are predictive of a lymphoma, always go for excision biopsy rather than a FNAC, because FNAC cannot conclusively tell about the presence of a lymphoma. Like your biopsy is the one that is going, because the architecture of the lymph node has to be understood and the cells has to be seen. So then only you can concretely diagnose a lymphoma. So that is the reason why whenever you suspect lymphoma or there are features predictive of a lymphoma, always go for a lymph node biopsy than FNAC. So these are the conditions, that's why I told you, which favor lymph node biopsy. Very important, clear? So then about lymph node consistency. Remember, completely unreliable. Based on the consistency, only in surgery, that too in the old textbooks they'll give the consistency. Even in exam sometimes it will be useful, but clinically completely unreliable and it's not useful for finding anything. Typically you will see the hard nodes, especially if it's non-tender, it is indicative of metastasis usually, and non-tender and fixed. Like hard, non-tender, fixed nodes always goes towards metastasis. Then you have a soft or firm node, usually go towards infection, and rubbery consistency. In exam, if they give rubbery nodes, usually it go towards a lymphoma. Classically, old textbooks will give Hodgkin lymphoma as a rubbery, India rubber consistency. But if you ask me, these and all consistencies and all is not going to help you really in clinical practice. That is not going to tell you whether it's a malignancy or not a malignancy. Any consistency may be seen in malignancy and lymphoma. So don't go by all those things in real practice. So these are some of the important points that you have to note about the lymph nodes. So then final thing is about the spleen. So the final thing is going to be on the spleen. This is the important secondary lymph node organ. To know about the spleen, once again it is very important to know about the structure of the spleen, again which can be done in a very simplified diagram like this, to know about the structure of the spleen. So what you are seeing here is, again, spleen is a lymph node organ, so definitely it has a fibrous capsule. And apart from that, spleen is generally divided into two things. One is called the red thing, which I am drawing, that is what we refer to as red pulp, which contributes to 75% of the spleen, or I can show it here. And the second one is the white pulp, which this zone, what I am drawing, so this white color area, this is the white pulp, which contributes to 25% of the spleen, white pulp. So what are the constitutions of the red pulp and the white pulp? So if you ask me about the constitution, and between one marginal zone is also there, which I will tell you later on. So there is one marginal zone in between here at this point. Here you can see a marginal zone. So this area, if you want, I can show you in this area. So these are the marginal zones. So this marginal zone is where is the marginal zone here? So they have not mentioned. So this is the marginal zone. You can see that, I mean, some books will give you under the white pulp, but some books will give that as a separate zone. So that is a, like it's your wish to understand it as a, with the white pulp or the separate zone as a marginal zone. But anyway, red pulp is 75% and white pulp is 25%. So what are the constituents of the red pulp? The red pulp is predominantly constituted by this kind of sinusoids. These are the vascular sinusoids you can see, which I am putting as a dot color structure. So these are the sinusoids. And the red pulp is divided into multiple areas by this tuberculae, and surrounding these sinusoids you can see this kind of areas. These are nothing but the splenic cords. These are nothing but the splenic cords surrounding sinuses, surrounding these dot color areas. There are some areas which are like just bland, like that's just painted with red in this diagram. So these are what we call as splenic cords of Billroth. This is what we call as splenic cords of Billroth. So why it is important? Because there are certain constituents. For example, the splenic cords of Billroth is the place where you have the splenic macrophages, these are the ones which are going to filter the blood. These are the ones which are going to swallow the senescent RBCs or destroy the senescent RBCs. A lot of area functions are there for the splenic cords of Billroth, which means the major constituent of the splenic cords of Billroth is the macrophages, or simply you can call it as the splenic macrophages, which is going to contain the splenic reticuloendothelial system, the splenic macrophages. That is what is going to happen. Splenic cords of Billroth. The most important function of the red pulp, if you ask me, most important function of the red pulp is destroying the senescent RBCs. Senescent RBC destruction. And next thing, in fetus, they can also contribute to erythropoiesis. If you go to the first video of hematology, there I have told the liver and spleen contributes in the first 2 to 7 months. In the fetal period, they contribute to hematopoiesis. So where in the spleen? It is in the red pulp. That's it. So after that, after 7 months, they regress and the bone marrow takes over. But in the 2 to 7 month mark in the spleen, the red pulp is the one that contributes to the fetal erythropoiesis. Number 3, platelet sequestration. Not only platelets, in fact, many other hematological cells can be sequestered in the spleen, especially platelets. Almost, if you want to know, astonishingly, 1/3 of the platelets, is actually in the body is actually sequestered within the spleen. So they serve as a reserve for the platelets, which is a very important thing. And let us see the white pulp. So the white pulp, what are the things that white pulp contains? White pulp typically contains, you can see the central one, these central ones. These are actually the follicles. We can see the primary follicles. These primary follicles are the ones which contain the B cells. This contain the B cells, and you have something called periarterylar lymphocyte tissue. These are the periarterylar lymphocyte area. So these are the so-called periarteryal. This is the arteriole. So you can say, I'll put in red. This is the arteriole, and this is the periarteriolar area. Periarterylar area is the one, as I showed you, this is the diagram you can see. The periarterylar lymphoid sheath is the one that is going to contain the T cells. These are the areas that are going to contain the T cells. Very, very important. These are the periarteryal area. This is going to contain the T cells. So these two, this primary follicle and the pulse, are the ones that are going to contribute to the predominant bulk of the white pulp in the spleen. Then finally you have the marginal zone. See, again I told you, marginal zone can be a separate zone, or you can put it under the white pulp also. This marginal zone is the one that is seen between the red pulp and the white pulp. So which is going to contain something called marginal zone B cells. remember these are specialized B cells, and in normal physiological state the marginal zone B cells are present only in the spleen. The spleen only will contain marginal zone B cells. Remember, like marginal zone lymphoma can happen in the spleen and in the node also, because marginal zone B cells have certain phenotype, and once they proliferate they can go outside the spleen and can settle in the lymph node and they can produce malignancy there also. That's called marginal zone lymphoma. But typically physiologically marginal zone is seen only in the spleen, in the body. There's no other area where you can see marginal zones. These are specialized B cells called as marginal zone B cells, which we will discuss in detail about the marginal zone B cells in the B cell development and maturation. So again, our thing is about putting everything under perspective and putting it as a easier way to understand. So how to put easier way to understand? So splenic histology we can put into red pulp, which is the major bulk 75%, and you can put into white pulp, which contributes to only 25%. Sorry, 25%. Maybe you can put marginal zone separately, or you can put marginal zone under the white pulp also. That is your wish, because different textbooks will give different thing, but I believe that marginal zone is a separate thing. I mean, because functionally they are distinct. They don't contain the usual things. That's why. The red pulp, there are two constituents of the red pulp. One is the sinusoids, where the blood flows, and the second one you have something called the splenic cords of Billroth. The splenic cords of Billroth is where you have the reticuloendothelial system, that is the splenic macrophages. Then come to the white pulp. The white pulp, and plus this is the place where you store the platelets, and the platelets are actually sequestered in the red pulp only. And white pulp is the place, there are two areas in the white pulp. One is the follicles, and second one is the periarterylar lymphatic sheath. The follicles are the places where you get the B cells, and the periarterylar lymphatic sheath or the perifollicular areas, which is similar to the perifollicular areas in the lymph node. These are the zones which contains the T cells, and the marginal zone is going to contain a specialized group of cells called marginal zone B cells. These are going to contain something called marginal zone B cells. So these are the important things. So in spleen, these are the sites of immune reaction. So this is where you are going to get the immune reaction and like sites of adaptive immunity in the spleen. So this is how about the histological differentiation of the spleen in general. So now let us move on to splenomegaly. It's a very important topic, splenomegaly. So we'll finish along with that, the architecture of the spleen. So what do you mean by splenomegaly? Splenomegaly, first, as we discussed in lymphadenopathy, we first will see on the etiology of the splenomegaly. So what are the etiologies? Number one, it can be due to reticuloendothelial system hyperplasia. Reticuloendothelial system hyperplasia, which means it's simply a red pulp hyperplasia. That's what I mean. So where you can get the red pulp hyperplasia? Red pulp hyperplasia, you will see whenever the splenic macrophages are very active and they are proliferating. So where they will get more active, especially in hemolytic anemias that is involving the spleen. It could be hemoglobinopathies like thalassemia. It could be early stage of sickle cell anemia. As we discussed, late stages they'll go for autosplenectomy because of infarcts. So early stage of sickle cell anemia, thalassemias, and other hemoglobinopathies like your hereditary spherocytosis, membrane defects, and you can also see in extravascular hemolytic anemias, typically where spleen is the major reason for hemolysis. So many hemolytic anemias will have splenomegaly because of the RES hyperplasia, which means the red pulp hyperplasia. Then you can get in immune hyperplasia, which means typically in this condition the white pulp is going for hyperplasia, which means it's a white pulp hyperplasia. That's what you're going to see. So where you will see this immune hyperplasia or white pulp hyperplasia? Typically you will see in infections. Lot of infections. Infections could be viral again. Infections could be bacterial, or infections could be parasitic and protozoal. Parasitic infections. For example, viral infections that commonly cause splenomegaly is Epstein-Barr virus, again HIV virus, CMV virus, hepatitis virus. Lot of viruses can cause splenomegaly. Bacterial cause, typically you can see in tuberculosis, Mycobacterium avium complex, leishmaniasis, especially visceral leishmaniasis, all these things can produce splenomegaly. Some examples I'm telling you. This is not the complete list, but some examples. Parasitic, typically they will expect malaria. Malaria is a classic example where you see hepatosplenomegaly, especially splenomegaly. That's where you see malaria. And a variety of autoimmune disorders. Typical exam, you need to know connective tissue disorders, especially rheumatoid arthritis and SLE. In the rheumatoid arthritis, if they ask you massive splenomegaly, the moment they tell rheumatoid arthritis massive splenomegaly, always think about Felty syndrome. Very, very important. And third area where you can see is in malignancy, lymphoid malignancies. Lot of malignancies and neoplasms. You can see splenomegaly. What are the malignancies? You can see in myeloproliferative disorders. You can see in lymphomas. The moment I put MPNs, it's are myeloproliferative neoplasms. Myeloproliferative neoplasms means it includes essential thrombocythemia, polycythemia vera. It includes primary myelofibrosis, CML. All these things can produce, can come under this myeloproliferative neoplasms. Then a lot of lymphoproliferative disorders like lymphomas and leukemias. Lymphomas could be Hodgkin lymphoma, non-Hodgkin lymphoma, or a hairy cell leukemia, or a CLL, or whatever it is. So these are some of the lymphomas. And it can be seen in large granular lymphocytic leukemia, LGL leukemia, or LGL syndrome. You can see in a multiple myeloma. In all these conditions, in neoplasms, you can see splenomegaly. Apart from that, congestive causes are there. Congestion can cause splenomegaly. So what are the congestive causes of splenomegaly? You can see in cirrhosis. Another cause of portal hypertension like portal vein or splenic vein thrombosis. It could be due to CHF and it could be due to schistosomiasis. Remember, schistosomia is very important cause of portal hypertension, which we'll discuss in detail in the hepatology section. So these are some of the congestive causes. That is because of the congestion, because the movement of the blood is poor. The forward movement through the splenic vein is not there. Because of that, you get congestion, and because the spleen gets enlarged. So this is what we call congestive causes. And finally, you have something called infiltration of the spleen with certain other substance. What could be there? For example, it could be lysosomal storage disorder. Typically, two disorders cause splenomegaly in the lysosomal storage disorders. One is the Gaucher disease, and second one is the Niemann-Pick disease. These are the two classic examples where you get splenomegaly due to lysosomal storage disorders. Then you can get with glycogen storage disorders. Then you can get with histiocytosis X, or now we are going to call it as Langerhans histiocytosis. Then you can get with splenic cysts also. So these are some of the important causes of splenomegaly. But please do remember, all the causes are not important. Hemolytic anemia, EBV, HIV, hepatitis virus, TB, leishmaniasis, malaria, all these things are important. Felty syndrome is very important. Myeloproliferative neoplasms, lymphomas, leukemias, then cirrhosis and other causes of portal hypertension, and finally lysosomal storage diseases and glycogen storage diseases are extremely important for splenomegaly. So these are the commonly asked things in exam about splenomegaly. But more importantly, they will ask you what are the conditions that produce massive splenomegaly. It's a very common question. So massive splenomegaly you can see in Thal major, you can see in malaria, you can see in leishmania, that is Kala-Azar, leishmaniasis. Then you can see in Mycobacterium avium complex, you can see in Felty syndrome, you can see in schistosomiasis and portal hypertension. You can see in myeloproliferative neoplasms. You can see in lymphomas, especially CML. You can see in Gaucher's disease, storage disorder, infiltration, Gaucher's disease. So these are, if they ask you, these are usual conditions that produces massive splenomegaly. So now the question comes, what do you mean by massive splenomegaly? That's what the question comes. So splenomegaly can be quantified based on a lot of things. So let us see how they are going to quantify. So you can quantify based on weight. You can quantify based on clinical examination, gross splenic weight. You can quantify based on ultrasound, length of the spleen also. By measuring the length of the spleen, ultrasound also, you can quantify splenomegaly. Weight is only post-mortem, but anyway, just for thing I'm telling you. So what is the normal spleen weight? Is less than 250 gram. Clinically, spleen must be impalpable. You will not be able to palpate the spleen near the left costal margin. That is what we call it as a normal spleen clinically. And ultrasound wise or mild, the tip may be palpated, splenic tip may be little bit palpated, the margin of the spleen, but that is also considered as impalpable only. Ultrasound length should be less than 12 centimeter. This is a very important point for entrance exam point of view. Then when you call it a mild splenomegaly, if the weight of the spleen is somewhere between 400 to 500 grams, clinically the palpable length of the spleen is less than 3 centimeter, and ultrasound it is in the range of 12 to 14 centimeter. When you call a moderate splenomegaly, when the weight of the spleen is 750 to 1000 grams, when clinically they are palpable up to 3 to 8 centimeter from the left costal margin, and if it is 14 to 18 centimeter in ultrasound. When you call massive splenomegaly, typically when it is more than 1 kilogram, 1000 grams, or when it is palpable more than 8 centimeter below the costal margin, or it is palpable beyond umbilicus. If the spleen enlarges beyond the umbilicus towards the right, remember always spleen grows towards the right iliac fossa, because they cannot go down because of a ligament called lienorenal ligament which blocks the growth of the spleen down, straight down into the left iliac fossa. So they generally go towards the umbilicus and towards the right iliac fossa only. So when they cross the umbilicus and grow, or when the palpable length from the left costal margin obliquely, if you measure, along the umbilicus, if it exceeds 8 centimeter, these are the definitions of massive splenomegaly clinically. Or in ultrasound wise, if it exceeds more than 18 centimeter, we are going to call it as massive splenomegaly. So these are the definitions. This is very important for exam, these three values. These are the definitions for massive, more than 1 kilogram, more than 8 centimeter clinically, and more than 18 centimeter length in ultrasound. All these things are definitions of massive splenomegaly. In general, CT is also one of the very accurate measurements of, to accurate measure of how to diagnose, how to find out a splenomegaly. So in CT, if you see the splenic width, that is the AP diameter of the spleen, if it is going to be more than 10.5 centimeter, this is considered as the single most accurate measurement for splenomegaly. In the CT, if the AP length of the spleen or AP diameter of the spleen, if it's more than 10.5 centimeter, that is the single best and most accurate method for diagnosing splenomegaly. Similarly, if the craniocaudal measurements, that is the height of the spleen in CT, if the craniocaudal measurements, if it is more than 14.6 centimeter, and again this is considered to be one of the very important accurate measures of splenomegaly in CT. But in exam, if they ask a single most accurate, this is what I will go. So if the splenic width in AP length diameter is more than 10.5 centimeter, that is what is a single most accurate measure for diagnosing splenomegaly. I'm not talking about massive, mild or moderate, just splenomegaly. That's it. So now we know about the different classes of splenomegaly also. After this, it's very, very important to understand about what do you mean by hypersplenism. What do you mean by hypersplenism? Remember, hypersplenism has no separate etiology. Anything that produces long-standing splenomegaly, if the splenomegaly is not quickly reversed, they can go for hypersplenism. So hypersplenism is not going to have any separate causes. But very commonly where we see hypersplenism in our country is in cirrhosis and portal hypertension. Very commonly we see hypersplenism where the spleen is congested. Because of that, the macrophages will get more active and they're going to it's going to sequester a lot of cells there. That is the reason. So hypersplenism. So two pathophysiology. One is sequestration and increased phagocytosis of blood cells. Both contribute to hypersplenism. So what you are going to see in hypersplenism is the classic cytopenias. That's what you see. And the most common cytopenia you are going to see in hypersplenism is anemia. So not only anemia, it can have leukopenia also. They can have associated thrombocytopenia also, or they can have pancytopenia also. All three lineages may be decreased, especially in long-standing splenomegaly. So all the lineages may be sequenced and they can be destroyed within the spleen. So this is what we refer to as hypersplenism. But the criteria-wise, if you ask me, the cytopenias alone is not enough for diagnosing splenomegaly. The patient, hypersplenism, the patient should have associated bone marrow hyperplasia. This is a compensatory hyperplasia because the cells are destroyed in the periphery. Your bone marrow goes for reactive hyperplasia. This is what we called as reactive bone marrow hyperplasia. Plus the patient should have splenomegaly. And all these cytopenias must improve or will improve after splenectomy. This is an optional criteria, not a mandatory criteria. They will improve after splenectomy. Because obviously that proves that it is hypersplenism, that the cytopenia is due to splenic sequestration and destruction. So this is what we refer to as something called hypersplenism. Remember, again, hypersplenism doesn't have any separate cause. Anything that produces chronic long-standing splenomegaly may have hypersplenism in general. And diagnosis of hypersplenism, patient will have cytopenia, plus criteria-wise you have to go for bone marrow, that should be reactive bone marrow hyperplasia with evidence of splenomegaly in any investigation or clinically, plus optional criteria is improvement after splenomegaly. All the cytopenias will improve after splenomegaly, and that is really, really important because that is the confirmatory point. Once you remove the spleen, definitely in hypersplenism, all the cytopenias will resolve. So I think we have covered extensively about the spleen also. And before concluding, we have one small topic that is about the MALT. These are called as mucosa-associated lymphoid tissue. These are called as MALT. The structure, because the MALT lymphocytes are having some separate, surface markers which we'll discuss in the B cell development and maturation. But as of the MALT is concerned, you can put under it two things. One is the Peyer's patches. And second one is the tonsils. Typically, the MALT, not only the Peyer's patches, you have this intestinal mucosa also, certain aggregates of intestinal mucosa also. So this MALT cells, especially the Peyer's patches and the intestinal mucosa and the tonsils, there will be one important things, because they got the mucosal area. So that is the reason why they come under this mucosa-associated lymphoid tissue. So this, what is the speciality of this MALT is, the first thing is they contain, special epithelium. Epithelium wise, they contain a specialized epithelium called follicular epithelium or follicle associated epithelium. So they contain a specialized epithelium called follicular epithelium or follicle associated epithelium, where they contain specialized cells. This follicular epithelium will contain specialized cells called M cells. What are the functions of this M cell? Whatever the antigens that are present in the mucosa, because a lot of commensals are also present over the mucosa, you know that. So these M cells will transport this antigens, they just sample, because you have to know what is happening around, you have to know the surrounding. So they sample these antigens, and by a process called transcytosis, they process these antigens through a process called transcytosis, and they will be presenting to the mucosal antigen presenting cells, and which in turn through multiple process they produce IgA, mucosal IgA. So which means this mucosal IgA is one of the important defense mechanisms against this organisms that are present on the surface of the mucosa. So that IgA production is actually dependent on these M cells in the follicular epithelium, because they are the ones that sample these antigens and tell it to the immunity that these kind of antigens are there, so that the commensals will live in the mucosa, but at the same time it cannot cross the mucosa and come inside and invade, because they secrete this neutralizing IgA antibodies, which means they can survive outside that mucosal layer, but not they can perforate the mucosal layer and invade because of the protection from the mucosa in the form of IgA production. This is a very important concept to understand. Mucosal IgA production, that is due to the presence of these M cells, very important. These are specialized cells that are present in the specialized epithelium called follicular epithelium. This is a very characteristic difference from other areas of the other lymphoid areas in the body, second lymphoid areas in the body. And tonsil wise, they are also will come under, typically they will come under the MALT only, even though they put under intermediate classification, but they will typically come under the MALT only. You know that there are 4 lines of tonsils, 4 groups of tonsils you have. One is the pharyngeal tonsils. Pharyngeal tonsils, these are commonly referred to as something called adenoids. And you have the tubal tonsils, which are present on the lateral wall of nasopharynx, which are present on the lateral wall of the nasopharynx. These are called as tubal tonsils. And these tubal tonsils, where they are present typically in the fossa of Rosenmuller, posterior to the eustachian tube. This tubal tonsils, if they enlarge only, they actually obstruct the eustachian tube. They are present just posterior to the eustachian tube, and they are present in the area called fossa of Rosenmuller. This is simple anatomy. And then you have this palatine tonsils. Palatine tonsils. Remember, these are present on the tonsillar fossa. This is actually present in the tonsillar fossa between the palatoglossal arch and palatopharyngeal arch. You have a tonsillar fossa. That is where you see this palatine tonsils. And finally, in the lower area, you see the lingual tonsils, which is seen in the base of the tongue. Base of the tongue. So this anatomical arrangement is what we refer to as something called Waldeyer's ring. This is what we call it as Waldeyer's ring. And one interesting point to note is that which of the tonsils will contain what epithelium. I mean, these are the areas that guard the oropharyngeal and the nasopharyngeal area. The nasopharynx and the oropharynx is actually guarded by the Waldeyer's ring. This is the first site of adaptive immunity in the body, to be honest. This is the usual place where the organisms gain access into the body most of the time. So that is why it is called the first area, the body to encounter adaptive immunity. So this Waldeyer's ring, that's why this Waldeyer's ring is of importance. And some important points only I will tell you that is important for exams about the Waldeyer's ring. If you ask me what are the epithelium that is seen in the pharyngeal tonsils, that is the adenoids, and in the tubal tonsils, these two will contain something called respiratory epithelium. That is ciliated columnar epithelium. That is what is going to be there. And if you ask me about your palatine tonsils and the lingual tonsils, what epithelium they contain? They contain the usual non-keratinized squamous epithelium. They are going to contain non-keratinized squamous epithelium, whereas your pharyngeal and tubal tonsils, the adenoid and the tubal tonsils are going to contain respiratory epithelium, which is nothing but ciliated columnar epithelium. And one more thing, which of the among all the tonsils which does not have cribs? It's a very important point, because cribs is a very essential point. Essential thing, cribs is a very important anatomical landmark of tonsils, which you can see grossly itself, this tonsillar cribs. So which of the tonsils will not have cribs? The answer will be definitely pharyngeal tonsils, that is the adenoids. They do not have any cribs. Prominent cribs will be seen in your palatine tonsils and probably in the tubal tonsils. You will have very prominent cribs, but lingual tonsils will have cribs, but they will have only shallow cribs. But remember, in exam, if they ask you which of the tonsils does not have cribs, definitely it goes towards your pharyngeal tonsils, that is the adenoid group only. So these are some of the important points that you have to note about the tonsils also. So we have discussed about all the primary as well as the secondary lymphoid organs in this lecture in a very, very detailed manner. So a lot of MCQs are there. Very trivial MCQs, very potentially small MCQs that you see in this particular chapter. But really it might be a very game-changing questions in exam, even though they look very simple, but these might be one-liners many times, and which might make you cause a lot of mistakes in exam, and especially silly mistakes, rather than the big ones which are clinical you will answer easily, but these are small ones which is very difficult to answer sometimes. So be careful. And with this we are completing the basics and the transition into the adaptive immunity. In the subsequent videos we'll be seeing on the T cell maturation and differentiation and B cell maturation and differentiation, and how the markers are going to differentiate in different lineages of the cells. See you.